Tēnā koutou kia kura tātou katoa. Ko Graeme Norton taku wēnawa, ko te mata o ronga kako, te maunga ko toki toki te awa. No heratonga ahau. Heratonga ararau, heratonga haukunui, heratonga haro o te kahu, heratonga takoto noa. Tēnā koutou katoa. This is the only slide you're going to get. I thought by about this time in the day you'd be at death by PowerPoint. What I would like to do, as Chris and Linda said, they came and saw us a few weeks ago. I'm the chair of the Hawke's Bay Health Consumer Council. That's a sector-wide initiative. It initially started from the DHB, but within a couple of months we took it sector-wide, so it incorporates our sole PHO. I just wanted to give you some context and then the position that it sits in the pecking order, a bit of a shape about how the council works, how we recruited for it, something on leadership and on our progress to date, and something of the future. There is a set of handouts that I'll put over the back. And that'll have a terms of reference and what our work plan is, as well as the structure within the, if you like, the DHB context that this sits. So I hope that'll make up for a lack of slides. Anyway, this is where I come from. So as the Whakataukia says, this is the land of 100 pathways of the life-giving dew, and whose beauty can only be seen through the eyes of a hawk. Just want to give you some context. 4 years ago, the way the DHB structure looked, had a board up here and the usual advisory committees. I think if you're in DHB land, you know kind of what they are. There's CFAT, DSAC and HAC. Community and Public Health Advisory Committee, Hospital Advisory Committee and Disability Services. So they sat out here. And then there's a Finance, Risk and Audit Committee, and then a Maori Relationship Board, and an Appointments Committee. And then there's the CEO down here, down to all those thousands of people. And 4 years ago it looked like that, and then they made a brave step and created a clinical council, and the clinical council is now sector-wide, and that's got within it GPs, nurses, senior clinicians, kind of not mirroring the structure of the hospital or secondary care. In fact, it's got pharmacists, allied health, so it's trying to get across the sector from a clinical perspective. It includes the Clinical Quality Advisory Committee of the PHO, their chair sits there. And this is now working incredibly well. So nothing gets up here that hasn't gone through here. And last year, after quite a lot of frustration about consumer engagement or the lack of through these advisory committees, they used to meet once a quarter and they used to get a lot of top-down information but very little context into the decision making. They decided to form a consumer council, which is here. And so they're both CCs. And then I'll go on now and explain, if you like, the relationship that sits across here and what happens here and also out there. So now there's no decision, if you like, on any significant change that might occur within the DHB that doesn't go through the clinical and consumer councils. As the chair of the consumer council, I also sit inside the clinical council, and a member of clinical council sits around our table as well. And in addition to the consumer members, there are also a number of people sitting either close to us or around that table. So the head of health services for the PHO sits around the table. And so we work in a collaborative style. The way the process worked was a bit like this. The DHB advertised for a chair and then appointed me as its inaugural independent chair. So I'm not selected by the Consumer Council. I got selected through a process that was publicly driven. And I've paid. The hourly rate sucks relative to the amount of work done, but that's fine by me because I'm 60 now, and for the last 20 odd years I had decided that by the time I got to this age I wanted to be in a position where I could give back into the community from my own skill set, and I've managed to kind of be in that spot where I can do that. From my I have a business life, but I have this particular life which is now significantly consuming me. I can't remember the particular date, but the date I got diabetes, age 52, was a rather pivotal moment. And from a person who had bugger all to do with the health system up until that point, and all of a sudden, bang, I was an insulin-dependent diabetic, was a bit life-changing. And as a result of that, that's kind of how I ended up delving into the health system. So apart from this particular hat, I also chair the diabetes leadership team for Hawke's Bay, because I got involved in the whole diabetes question after I got diagnosed. So I got appointed as the chair, and then we sent out to every known consumer group in Hawke's Bay the information about the potential for people being appointed to the Consumer Council, and invited applications, CVs. We had a series of different parts of the health system that we were trying to identify whether people had a particular interest or persuasion around it. We got about 35 applications, and then we sat down and worked our way through a process to try and get a cross-section of the community, which is bloody near impossible with just 15 people, but that's what we tried to do. So we've got a really interesting cross-section of society, ages, ethnicities, experience of healthcare, trying to get as broad a group as we possibly could get. They were initially volunteer positions, but since after 2 or 3 months I managed to persuade the board that, given that they had saved money, I'll come to how they save money in a minute, that these people should be paid. And so they are now paid the same kind of level that they would have been paid had they been consumer members on those advisory committees. What the board then did, once it got established, was essentially not to disestablish those advisory committees, the CFAC, DSAC and HAC, but they've pretty much put them in hibernation. I know they're technically required to be there by law, but what happens now is that all of the board members are members of those committees. There are no consumer reps on them, and they don't meet. And why they don't meet is because the board feels that it's getting what it needs from a combination of the clinical and consumer councils that are working through the CEO to the board. So next step. Once this group got established over the first few months, it was really important to start enabling leadership within this group. So if you think of this as a grid, with the people this way and the areas of health this way, we identified the particular interests and abilities of the people that were in the room. And then we've essentially provided a leadership role for each and every one of the people around this table. So, for example, we have a lead in women's health, and a lead in Māori health, and a lead in Pacific health, a lead in mental health, and that particular person also looks after addictions. So we've enabled these particular people to have leadership roles in these areas of health. What that enables for us is, as a number of people have already said, this health system is really complicated. And what we're doing is infiltrating the consumer voice in two directions. One, through all of the systems and activities of the health system. So there are steering groups and there are working groups and there are all sorts of groups working on change, design of various aspects of the health system. So we've got, for example, an integrated urgent care project at the moment, which is trying to get a better system of care for urgent care in Hawke's Bay. So there's a steering group for that, and there's various working groups around that. And so our 15 people, plus the connections with whom they are connected, are now being placed in positions of contact in those groups to enable a systematic consumer voice to be heard at the table. In addition to that, the responsibilities of these people are to go out to their networks in order to gather information and understanding. My role as the leader is not to say, here's the plan, follow me. It's much more to enable them to bring their voices to the table and then to articulate those, and often they are voices, not one voice. So we are often, in fact, providing a range of views to the board or to whoever the decision makers are, because actually the community is has multiple views, and that's okay because there's often not one right way to do something either. So my role is more of a coach than it is of a, that kind of traditional leader, if you like. We've made quite significant progress to date. I mean, the organisation's only less than 12 months old, so it's only just learning how to walk. But at least it's in a position now where we've been able to start making some change. One of the changes we've made more recently is to speak rather firmly with health bureaucrats. When you're in the system, of course, you end up with an agenda and a set of contents for our monthly meetings. We're part of the schedule, so what it means is that we meet every the second Wednesday of the month, and the second Thursday of the month. The day before is the clinical council, and a fortnight later the board meets. So we've issued some pretty clear instructions to those people who come in front of us, and that's now been adopted elsewhere. Essentially, we're saying to them, don't walk us through what you've sent us. We will do you the courtesy of having read it, and if we don't understand it, we're going to ask you a question. If you give us more than 6 slides, then you're wasting our time. We actually want to talk with you, not to be taken through a complex set of slides, because that's what we're here for. And it's been quite interesting, those instructions are being followed, and the conversations are getting broader and more in depth. I'll give you an example. I think Chris and Linda were there. Our gastroenterology and endoscopy services are going through a period of change, and they've developed a business case and a new model of care, and so they came to Consumer Council last month. There were 2 offal doctors, as they call themselves, plus the clinical service director, and they sat around our table and we chewed the fat over the model of care and shook hands on it. And that was a really, an engaging conversation. They got a lot from it. We got a lot from it. And we moved forward with a recommendation to the board as to the direction they were headed in. So it's a really collaborative, interesting process that we're on. If I can look out to the future, what I see is that pretty much there is a more and more an embrace. The positive side of me says there's more and more of an embracing of the consumer view in the room. We are not there yet. You can tell by the body language in some of the places that I go that some have got a long way to go to accept the possibility that there might be an alternative view, but it's begun. And I think that one of the things that has been powerful is that previously there was a consumer group in Hawke's Bay. It was effectively managed by a 5th level manager within the DHB. It met, but nobody ever heard about what it got up to, and very rarely did any of its information or experience land at the decision-making point. Now the chief executives of both the PHO and the DHB, the board of both organisations, looks to the Consumer Council for real serious input into its decision making, and that, if you like, vote of confidence has been incredibly important to enable us to get on and get stuck in. Happy to take questions from here.